Welcome to Tribune Talks. I am the Dhaka Tribune editor, Zafar Sobhan, and I'm joined by an august panel from around the world to discuss COVID-19, the global perspective, and specifically with reference to developing countries, which I think is of special interest to us here in Bangladesh. I'm here with Dr. Rajiv Chowdhury, who's an associate professor of global health and epidemiology at Cambridge University in the UK, Professor Officer Franco, the director of the Institute of Social and Preventive Medicine, University of Bern in Switzerland, Professor José Faria, who's the professor of medicine at the Pontifícia Catholic University of Paraná in Brazil, and here in Bangladesh, Dr. Maliha Mannan, MD, MBBS, and Masters in Healthcare Leadership. I think all four of my colleagues here will have a lot to bring to this discussion and to this debate. And let's get started with Rajiv. Why don't you kick us off, and let's talk a little bit about the situation in Bangladesh. And you know, you have you've got a model in place which you've been working on. I think why don't you kick us off and let us hear your thoughts on how things are in Bangladesh and what you see coming in the next few weeks, perhaps.
Thanks for inviting me in this very interesting discussion. I think talking about Bangladesh, we have all been following the progress, how the epidemic is panning out in this country, and we know that based on the recent stats, I think it's about 100,000 plus new infections identified in Bangladesh so far, with hundreds of deaths also piling up every day as we go. At one point, I think the numbers were doubling every 3 or 4 days. And of course, these numbers are only representative of the tests that you are doing. So given the stats that we know with respect to the testing in this country compared to many other countries, many other developing countries, because we are talking about developing countries today, I think has been slightly less optimal. And as a result, the numbers that we observe in Bangladesh probably is an tip of the iceberg, because I would have thought that the community spread has occurred all over the country, and the numbers are perhaps not representative of the true extent of the infection in this country thus far. With respect to going forward, I think we do expect this to keep piling up, the trajectory to keep going upwards, unfortunately, because at the moment the country only has some hygiene and other physical distancing measures put in place. The country has gradually coming out of the previous lockdown, which were put in place for a couple of months. And it came out at a time when the rates were still rising. And so at the moment, without any proper intervention put in place, I don't see the numbers coming down in the next few weeks, unfortunately.
Sure. And I mean, I think one of the problems we're facing here in Bangladesh is we're doing maybe 17,000, 18,000 tests a day, which really doesn't give you much of a handle on what the actual numbers are. What do you think if I could just stick with you for a second, Dr. Rajiv, what do you think a optimal level of testing would be for a country our size, 160 million people? What should we be aiming for to really get a sense of what's going on?
I think having perhaps numbers 5 times more than what you are doing at the moment would be a good start, because at the moment this kind of zonal lockdown proposal which we are considering in Bangladesh, as far as I understand, where the main principle of defining those zones would be based on the number of new infections per 100,000 people. And
Right.
at the moment, it's about 40 to 60 in the cities and about 10, I understand, in the rural areas. That's the plan. But then, this is entirely then based on the number of tests you do countrywide, nationwide surveillance, nationwide testing structure, reporting in real time, so that everywhere, which is a cluster outbreak, which is now, can go from red to yellow. So it's entirely based on testing. So improving the test statistics is essential for any intervention to go forward, especially with zonal lockdown.
Sure. And Dr. Maliha, if I could just bring you in here. I mean, I think one of the things I've spoken with you about and you've written about as well is perhaps the need for antibody testing. Because really, if you want to have comprehensive testing and really get a sense of where the general population of Bangladesh is, perhaps that's the best way to go about it. Is that something that you could talk to us a little bit about?
Yes, as Rajiv was saying, we need to scale up our testing, and both RT-PCR, and now that we have crossed almost 3 months of COVID in our country, and the cases are rising, we have many, many asymptomatic cases all around us, and disease surveillance, as I spoke to you earlier as well, that's important. And yes, we do need to start the antibody testing, because if we are talking about any immunity passport, although that is also not currently, we don't know, we don't have enough scientific evidence of how long the immunity lasts. But even then, we do need the antibody testings introduced in the country to figure out how many people were actually infected. And if it can be done in a low-cost manner, even better. It will be effective. We have to make it available to for all levels of people.
Sure. Okay, thank you. And now, Professor Faria, if I could bring you in. What is very interesting to our audience here in Bangladesh is, of course, we don't typically get the opportunity to hear from experts from other countries, and specifically your expertise in Brazil, which is one of the worst hit countries in the world right now. But we also figure that there's probably a certain amount of commonality between the Brazilian experience and perhaps what might be down the line for us here in Bangladesh. So if you could tell us a little bit about how things have panned out in Brazil and what lessons there may be for Bangladesh in terms of tackling the pandemic in the coming months, that would be very helpful.
First of all, thanks for the invitation, Zafar. It's a great pleasure to be here with some friends, Rajiv, Oscar. And well, we now have 3 months of the epidemic in Brazil. It all started in the last week of February in the city of São Paulo. And what we saw in the last few months was a great rise in the numbers of COVID-19 in Brazil. By the end of the day today, Brazil will reach 1 million cases, 1 million confirmed cases. We have every day something between 20 to 30,000 new cases identified. And we are in an average of at least 1,000, 1,200 deaths every day. By the end of this weekend, we probably will reach 50,000 deaths in the country. So it's not wrong to say that Brazil today is the epicenter of the epidemic in the world. It developed, the disease developed in different ways in different parts of the country. Brazil is a very large country. You have the wealthiest part in the south and in southeast of the country. You have the less developed in the north and northeast. And unfortunately, this made a huge difference in the way that the disease impacted the health system. Most of the cases, most of the deaths are in this less developed part of the country, mainly in the north part of the country, where is the state of the Amazonia, where the Amazon jungle is. The infrastructure of health was not prepared for that. I would say that the country was not prepared for the epidemic as a whole, but here in the south, we managed it in a better way. And in most part of the countries, what we had was just damage control. And everybody knows that the president of the country was in a denial. He's still in a denial of the disease, but I was mentioned previously to Rajiv that early in the crisis, the Supreme Court decided that the epidemic would be managed by the governors, so in a decentralized way. And I think that this helped some of the states that were more prepared. And so that's how the things went in the last 3 months. Here in the south, we are now going up in the curve. We're expecting the next 2 or 3 weeks to be the worst. The occupation rate of the ICUs here in the south is something close to 70%. So we are still not talking about lockdown. But if things get worse, we may even consider it as Maliha and Rajiv talked that there's a possibility in Bangladesh.
Okay, super. Thank you, Dr. Faria. Now, Dr. Franco, you are based in Bern, but if you could tell me a little bit about building on what Professor Faria has said, let's talk a little bit about the global situation, if we could. Touching on Latin America, which is apparently now coming up as a sort of a new epicenter, together with perhaps you could say South Asia and other parts. But if you could give us a global picture of where the epidemic is right now, the pandemic is right now, I think that would be a helpful place for us to start this discussion.
Sure, Zafar, and thank you again for the invitation to be here. Let's start with the numbers globally. We have 8.5 million cases and almost 460,000 deaths right now. If we look at the distribution of these cases and deaths, we see how almost 70% of the cases are right now in the American continent. And we have that 4 of the top 10 countries, US, Brazil, Chile, and Peru, are located in Latin America and in the American continent. So when José was talking about how Brazil is becoming the epicenter of the pandemic, I would say the epicenter of the pandemic is Latin America. Brazil is the most populous country, and yes, is being most affected, and is expected to continue to increase in the number of deaths. And it's important to also understand that the region is still 1 month or 2 months before they reach their peak. And then if we look at the number of deaths per capita, we see that still the countries that lead this ranking is Belgium, United Kingdom, Italy, Spain, and Sweden. And the countries in Latin America, such as Ecuador, Peru, and Brazil, are starting to climb in the ranking. If we look at recent trends in number of percentage increase in new cases, we see that the countries that are leading is Guatemala. We see Bangladesh also among the top 10 in terms of proportion of new cases is 4.4% approximately new cases per day. And we see Guatemala, Brazil leading. And in number of deaths, we saw a recent gigantic peak by India that suddenly in one single day had 2,000 cases of death. And Bangladesh is also very close in the top 5 in terms of the increase of percentage of deaths. So what we're seeing is a pandemic that has been migrating, going from being an Asian issue, an European issue, and right now it's an American issue. And I hope it doesn't come your place, the new epicenter. And I hope you learn from the mistakes that other countries have made and put strong measures to be able to prevent what is occurring right now in a region like Latin America.
Okay, thank you. Dr. Rajiv, if I could bring you in, I think that's a good segue to let's talk a little bit about, about lockdowns and the timing. We've recently relaxed the lockdown in Bangladesh, and we could talk a little bit about the timing and the manner of that. And also perhaps a lot of people would have said that the lockdown we had in Bangladesh was not as effective as they would have hoped it would have been. We didn't really see the numbers coming down. So given these two realities we have here in Bangladesh, if you could comment on those a little and perhaps suggest a way forward for the next couple of months, what would really be the best way for the authorities to deal with the situation here in Bangladesh, given what the realities on the ground have been from my experience of the last 2 months or so?
Thanks. I think, first of all, I think we have to, if we want to do well from here on, I think we have to acknowledge and appreciate the mistakes that we have made. And there has been a number of mistakes that have been made in Bangladesh as well, just like many other global health regions that we study. As a global health, public health physician, I try to study different countries, how they're responding. And if you talk about Bangladesh, it did go on to the lockdown phase, just like many other low and middle income countries when the cases were rising. Although we did talk about the risk communication, letting the people know what they're actually supposed to be doing is important. The way the lockdown was designed and implemented, I think there are questions around it that, we called it Sadharon Chuti or general holiday, not lockdown. And that, I think, was slightly misleading when it comes to, the general public to understand what they actually have to do. And there are reports that I read, I think a couple of days ago, that came out from the cell phone companies in Bangladesh, suggesting that actually during that lockdown period, about 60% of the people were on the move. So that kind of shows that the lockdown was not really, properly implemented in Bangladesh, at least not in the, rural or semi-rural areas. So that was, I think, one learning, if you like, from for us, and that's probably the reason why we were never actually on top of controlling the rates. And then, of course, when you have this kind of social distancing put in place, that has a knock-on effect on economy, on people's compliance in general. And then at one point, we realized that we have to keep the economy going. And because a good proportion of Bangladeshis, just like many other low and middle income countries, they are based in informal sectors. And so we wanted at the time to lift the lockdown gradually. But then we talked about this before. When you want to come out of the lockdown, what the other countries have done elsewhere in Europe or in even East Asia, you have to abide by a set of rules. So, for example, the number of new cases are going down, the number of deaths are coming down, your infrastructure for ICU and hospitalization capacity is improving, because once you lift the lockdown, there is a possibility of a second wave. Can you then cope with that, incoming of new inflow of patients? So none of those boxes, I think, was checked when we lifted the lockdown in Bangladesh, unfortunately. And that basically was another reason why we see this huge surge now of infection with, I think, the country now formally has moved to what we call the fourth stage of pandemic, where you have the whole country would have many clusters, many hotspots of outbreaks. And so that's the unfortunate situation where we are at the moment. Now, going forward, what can be done? I think the only way to perhaps reduce this huge surge of cases would be going into some form of lockdown. Now, that could be a generalized lockdown, that could be zonal lockdown. But again, as we have been discussing, these kinds of hotspot-based zonal lockdown or generalized lockdown needs to be based on a good testing infrastructure, so that in real time you actually can, know that where you have the new increase or decrease of cases, and you can have that system put in place accordingly. You also need some other aspects like the within and outside zone management protocol, and that is a complex task, because you have to involve different parties, and that also needs to be put in place. I think such work is currently underway to do that.
Yeah. Dr. Maliha, if I could bring you in, I mean, I think you had mentioned that one of the challenges we face is that, if you want to enforce a lockdown, or if you want to really, have a staggered lockdown, there are various strategies which have been put in place successfully by many countries and many governments. You need better data than we have in Bangladesh. And I think the real fundamental problem we're facing is we don't really have the data which is sufficient to be able to know how to sort of manage, manage a lockdown situation. And of course, you'd mentioned enforcing the lockdown is very difficult. Now, some people have suggested that one possible solution would be to have kind of a curfew-style lockdown, which, of course, there are civil liberties issues surrounding that. But do you think that might be a possible solution for us, given, the situation here and the fact that we don't really have the data that we need?
Well, I don't want to talk as a policymaker here. And coming back to, I saw Rajiv's model. He spoke of mitigation measures. You spoke of three kinds of scenarios. You said the suppressant, that was it, right? The suppression measure, where that is more like a curfew and it's more imposed lockdown. And you basically spell out what you can, you cannot do. So curfew style lockdown, I am still not sure whether it's appropriate for the country, because as I said, I re-emphasize that it comes on with other things. Like if you break the curfew, what do you do? If you break the social distancing protocol, if you break the timing and you're out there, are you going to take the person into custody? How many people can
that's
you take
another
into
problem.
custody?
Yeah,
That's another problem. That is not solving the social distancing. And the other factor is that, yes, the policymakers can come up with any kind of measure they want. I mean, of course, not any kind. It has to be strategically done, which is appropriate for the country. We are a very large country in terms of population, and we still don't know what is going to be our peak. Are we reaching our peak? Are we at the steep curve? When do we reach the peak? Someone says it's going to be September. Somebody says it's going to go even faster than that. So how do you mitigate that? You have to slow down the rate. And to slow down the rate, what other measures can be taken? Okay, you do the lockdown, and yes, disease surveillance is must. If you don't have the data, then talking about zones will not really help. You have to have data where the cases are coming from. If you're working only on, as I said earlier, like if you're only thinking of aggregate data, okay, I'm getting 52 amongst the 353,500 cases. 500 cases are coming from this particular area, or 20 cases are coming from that particular area. But it's really not, feasible. You have to have addresses of the people, of the cases, and all individual data to select the hotspots, to go into that zonal lockdown, even if you are thinking of going into zonal lockdowns.
Yeah. What about other sort of solutions, such as, for instance, masks? Could that be part of the solution? Or, for instance, you say, okay, because a lot of countries have operated without a lockdown. I'm not sure if I could bring in Professor Faria. Does Brazil have a lockdown? Sorry, yeah.
Sorry, could you say it again, Zafar?
Has Brazil had a lockdown?
No, just some cities, in fact, in the north part of the country, they had a lockdown for like 2 weeks, mainly the city of São Luís in the state of Maranhão. And this happened mainly driven by the high occupancy of the hospitals. There were no ICU beds available, so they decided for the lockdown. But I think that after 2 weeks, they just lift the order of the stay at home.
What about mask wearing? Is that a big thing in Brazil? Has that been successful, or is it like in the US, you see people who are resistant to wearing masks?
There are some cases of resistance, but in general, I think that this measure was fully adopted by the population. So if you go out in the streets, everyone is now using masks. So in my state, it was determined by a law. So it's out of the law to walk in the streets without wearing a mask. And that's why it worked, because policymakers decided to determine that it's now an obligation to wear the mask.
Okay.
Zafar, can I just add a supplement with Dr. Maliha and Professor Faria on the lockdown issue? So I think, when we talk about mitigating the COVID-19, or reducing the infection. I think we are talking about reducing the transmission from one person to the other person. And this contact reduction, this transmission reduction is basically the holy grail for controlling this disease. Now, you can contain this person-to-person transmission when the infection is or the epidemic is at very early stage without any lockdown, such as what was done in South Korea, for example, and where when they had only few cases, what we call as the stage 1 of the pandemic, when there are only some cases with some positive travel history who came to your country, and then you identify those people, you quarantine them properly. If they have any contacts, you trace them, and then you quarantine them as well. Now, that's something, if you can do it really well, you don't have to go on to lockdown, perhaps, because you're containing those at the very outset. But in Bangladesh, that was not the case. We could not do that very well at the beginning. Now, when you then move on to stage 2 or stage 3, when there is extensive community transmission, then what do you do? The whole point of lockdown, or if you like, strict social, distancing or suppression, no matter how you call it, the main way it works is that it cuts down the contact between two individuals, the transmission from one person to one person, one household to the next household, and that's the way it actually works. And in a country like Bangladesh or Brazil, where population density is extremely high, where people are very much used to having joint meetings, group congregations, the contact pattern is very high, and so in these kinds of places, what we call the reproduction number, or R, would be very high. It would probably not be 3, it might be even more, because it's very dense population. So in these kinds of populations, just trying to contain the population by having just this kind of hygiene practices or wearing masks is probably not going to cut it. That's what we have seen worldwide when it comes to the evidence. You talked about countries where lockdowns were not in place. Brazil is one example that has been mentioned, and it has now 1 million plus cases. Right. And then you talk about Sweden, where there was no lockdown. This has one of the highest rates of death and new cases in the whole of Scandinavia, if not the whole of Europe. So not having lockdown it has shown to be unsuccessful in reducing the rates. I don't know if Oscar wants to come in at this point.
I would love to, because I think we are forgetting the big picture here. And if you don't mind, I would like to give an overall framework and use a specific example to explain why. First, let's start with the word pandemia. It comes from the Greek. It comes from pan, that is everyone, and demics, which is people. It's a problem of everyone. It's a problem that affects all the people. So it depends on all the people. We are treating it as a health problem, but nobody owns a pandemic. It's of the entire society. If we look at a country like Peru, Peru has 19 million people in the country, and right now is in the 6th position with almost 250,000 cases. Peru was the country, or one of the countries in Latin America, that made a lockdown the soonest. And they were conscious that people needed to have economic support. So they decided to give them all something like $250 per household. Now, the problem is two things. Why is Peru, if they had a lockdown, why are they having 250,000 cases now? Well, two things. One is 50% of the population do not have a refrigerator. So they cannot store food. They have to go to the markets to buy the food. The markets became the focus of contagion. And the second, because they needed the money, they went to the banks. And the banks were full of people where the people were claiming the money for their support. And they got all infected in the banks and the markets. What it's telling you is that policies do not bring a solution if they are not fitted to the culture and to the country. If in Sweden a no lockdown might work, that doesn't mean that it's going to work in Bangladesh or in Peru. The argument in Sweden is that 50% of the population in the one person per apartment is the density they have. They had all, for them, 2 meters of distance between human beings is not such a large distance as for a Brazilian or a Colombian, which we are very used to be close to each other and hug each other.
Yeah,
So
Bangladesh too.
we need to, the policies per se, quarantine, lockdowns, etc., they need to be fitted to the country and to the culture. They cannot be just brought from other countries. And we need to understand that this doesn't belong to the doctors or to the epidemiologists. This belongs to the psychologists, to the economists, to absolutely every single member of society, because this is a problem of everyone.
Okay. Now, Dr. Maliha, I think you actually wanted to come in on that, right? There's an issue about masks. And one of the things I'd also like to sort of put to you is that, I mean, here's the thing. We have talked about the situation here in Bangladesh, but I would actually say that given the fact that it's been 103 days since we had our first case, the fact that it's only reported 105,000 cases, and it's just 1,388 deaths is actually less than I would have imagined. Now, it could be that because we're not testing enough, the caseload could be much, much higher, and we're simply not aware of it. Similarly, it could be that the death count is being undercounted, but my sense is that in a small country like Bangladesh, it can't be undercounted by all that much. And so if you look at the numbers, for instance, which Professor Faria mentioned in Brazil, or the numbers we've seen in the United States of America, massive difference. You know, we're talking about, you know, on several days of 1,000+ deaths a day, whereas in Bangladesh, we're talking about 40 deaths a day, 50 deaths a day. Even if that's undercounted by, you know, by 100%, we're still talking about 100 deaths a day. It's really not that close. And given the fact that with this densely populated country, given the fact that the lockdown was really not followed, how come things aren't actually worse than they are? Do you have any sort of thoughts on that issue?
Well, I think there was a report recently that said that during May we had more deaths than usual in the other years, and maybe that is due to COVID. And if we had tested more, let's say if we had tested 3 times more, the death would have been 3 times more as well, but maybe the ratio would have remained the same. And regarding the numbers here, I don't know if you want to call ourselves lucky. I'm not sure about that, because it has shown that pandemic is here. It has reached. A lot of people had said it wouldn't even enter the country anyway. That's a different topic. But I don't know, Rajiv, do we have better immunity? Is that it?
So first of all, I mean, there could be several.
Coming back, sorry. As I said, as I mentioned earlier, in my house, I had a couple of cases. My daughter was a COVID positive. I was tested negative twice, but I had the symptoms. And when the antibody testing comes, I will do the antibody testing to see whether I was infected or not. The 3 of my household helps, they were infected, completely asymptomatic. So what do you make out of that?
I think there could be several reasons for the somewhat lower number of cases or deaths that we see in the subcontinent, not just Bangladesh in general. And some of the reasons you've already mentioned: lack of testing, under recognition, you know, perhaps some misclassification at the hospital as well. All of those are important. But at the same time, you know, you have to understand the demography of the population as well. In these countries, the proportion of young people is far more
higher
compared to the West, where you get perhaps 30-40% people beyond 60. Here, you know, it's mostly a young population. And we know that for COVID, the high risk group is obviously, you know, elderly individuals. But having said that, I think India has recently published a report on sero survey that they have done in a representative sample over some 70 different districts spread across all of the states in India. They looked at the antibody levels in people, and in some of the highly contagious or high intensity COVID areas, the report suggests that there could be 30 to 40% people already exposed, infected to it, which means that from the same areas, the reported incidence was about, say, 5%, but actually the prevalence is about 40%, 35 to 40%. So that just goes to show what we see in terms of numbers in these countries is just the tip of the iceberg.
But surely, if if you look at it from another point of view, if the prevalence is high, then that means the fatality rate is much lower than we had anticipated. Okay?
Well,
so if you have 5% of the population and a certain number of people are dying, but if actually it's 40% of the population, the same number of people are dying, that means the percentage of people who get COVID-19 who actually end up succumbing to the disease is far lower than was once feared.
I think you're right. I think you're right, Zafar. But you can think of explanations that we all know that COVID has triggered a lot of social stigma in low and middle income countries, where people are intentionally underreporting their symptoms. They're not even going to hospitals. Sometimes they're going to hospitals but being turned away by. We have read this kind of reports from worldwide, from many countries.
That's certainly the case in Bangladesh. Yes,
and that might be an explanation where people are not being recognized in the system, and if you couple that with the absence of a nationwide death registration system in Bangladesh, which doesn't exist in Bangladesh or in many other countries. So you're not really picking up the true deaths due to COVID. So lots of deaths that's happening in Amazonian rainforest or in rural areas in Colombia or Bangladesh. There are people dying at community level at households that are not really recorded. So there could be some systematic under-recognition, under-reporting. At the same time, there could be some misclassification in the hospital as well, where people are being, the cause of death has been mentioned as, say, heart failure. Whether this is heart failure or heart failure that's triggered by COVID infection, you don't know.
Yeah.
So there could be several reasons that there are deaths happening, but they're not really attributed to COVID. That remains a possibility. But we have to have, as Maliha said, we have to have data to actually and lots of testing to actually get to the bottom of it.
The other problem, if I can interject, the other problem we have seen is that the non-COVID cases, the chronic cases, the cases like, let's say, people with kidney failure who need dialysis, people who were scheduled to have some sort of heart procedure, they're also not getting their treatments done, because that is simply not as essential. And some of them are not getting admitted in the hospital. So these are also comorbidities. So if that is also not addressed, and somehow they're also getting infected, so you have more numbers of cases coming in, more numbers of morbid cases. So that's another problem. And I want to ask Dr. José and Dr. Oscar, how you're dealing with the non-COVID cases. I'm sure you have systematic triage, COVID, non-COVID, segmented areas. Also, are you doing a lot of telehealth, telemedicines for the non-COVID people to get their regular checkups, chronic illnesses under check?
I give the word to my friend José.
I'm just going to start just to point out that because you were talking about under recognition of the disease, and Rajiv mentioned the Amazon jungle, but I will bring it to the main cities of the country. In some cities, we had the number of patients being hospitalized by acute respiratory distress syndrome without defining the etiology for that. It's 10 times higher than last year. 10 times. So what is that? It must be COVID-19. It must be some problem about testing. There are people dying, and you have the result of the test like a week after this patient died. So under recognition is a big problem in Brazil. We know that. We just can't estimate how big it is, but for sure it's playing a major role here in our country.
Okay.
Maybe just to add, if we look into Europe, for example, that you will think that maybe they're doing a better job. Excess deaths that have not been registered under recognition has also occurred dramatically in countries like the United Kingdom or even in the Netherlands, where we see under recognition of 50 or 40%. So while the United Kingdom has reported some close to 42,000 deaths, the reality could be 60 or more. Rajiv will know better the numbers, but then the recognition of the deaths, I think, is something that affects the world in general, In low and middle income countries can be even bigger. In Indonesia, is expected to be close to 90%. So it's something that is occurring everywhere, and in Brazil and probably in Bangladesh as well, is something that is affecting the count of the deaths.
Yeah, and could you, Dr. Maliha had a question in terms of what are you seeing in other countries outside of Bangladesh is in terms of the stress which is being placed on health systems for dealing with non-COVID patients, and that's also a risk factor. That, you know, a lot of people may die not because they have COVID, but because they're not really getting the treatment they need because so much of the health resources are being devoted to COVID. Is that something we're seeing around the world?
José?
Yeah, and it's not only that. People are afraid of going to the hospitals.
Yeah.
Sure. We see that in Bangladesh as well. Yeah.
For example, the search for cardiovascular emergencies in the city of São Paulo decreased by 70% in the last few months. So what happened? Where are all the acute myocardial infarctions? So are people at home? Did the number drop for some reason? Yeah, maybe it can happen, but by 70%, people are dying at home, afraid of going to the hospitals. So we are now allowed to make appointments on the internet, but the patients in Brazil are not very used to that. So in my opinion, it's not working. And what we are now trying to do is to make clear to the population that some cares with some chronic conditions cannot be postponed. And this is really happening in Brazil. And we are waiting for another wave of people with emergencies not related to COVID-19 in the next weeks, because these people are just not searching for emergencies, are not searching for care for their chronic conditions.
Mm-hmm. Yeah. Maybe if I may add, Zafar, from my side, I think there are three aspects that are key besides the heart attacks and the problems with the cardiovascular health that José was talking about. One is cancer, because screening programs are not being followed. So what we're going to have is tumors that are going to be in a far worse state when they come to the hospital. The second one is immunization programs. So children are not being able to receive the vaccination that they should receive. Mm-hmm. So we might lose herd immunity in measles or other diseases that will affect a great number of children. And the third one that nobody talks about, which is going to be a new pandemic, is mental health. For those that suffer the disease and those that are not suffering the disease, everyone is experiencing anxiety, depression, insomnia. 40 or 50% of the patients are experiencing post-traumatic stress disorder. So these are three problems that I think are time bombs that are going to be hitting us back as we progress with the pandemic.
Yeah, no, absolutely.
I think this point about losing the herd immunity that we have achieved in the many years on measles, on other infectious diseases like tuberculosis, for example. You know, lots of people are not able to come in South Africa, for example, to take their regular TB treatments because the TB clinics are overwhelmed with COVID patients. So all of those kind of indirect hits in other fronts where we had made a lot of development progress in the past decades are also at risk at the moment. And it's a great challenge for the health systems to adapt, to repurpose how we can configure our health systems that would not only be able to tackle this kind of pandemic, but also would make sure that the other kind of more widely prevalent, already endemic diseases are also not forgotten or ignored. I think it's a great challenge for the policymakers in all of these countries.
Yeah, Maliha, if I could ask you, I know you have written about the challenge of dengue, which is a seasonal problem here in Bangladesh, and is something we have been concerned about. And I think you flagged this perhaps a month and a half ago. Now that we've moved on, is this something, what are you seeing in terms of how the COVID epidemic or pandemic has impacted our dengue preparedness? Has that been an issue? Have we more or less addressed that since you've written about it?
I've worked closely with the dengue program director at DGHS, and they're very serious about taking this management of dengue and the awareness program of dengue as well. And this is one area that the government has actually worked on, and it is still on the agenda. And a lot of communication regarding awareness generation amongst people, how not to have the breeding size and the city corporation being involved in it. They're also building a dengue platform to do some prediction analysis of how it's going to be in this year. A lot of work are already underway. So I think maybe, possibly, we will not. I'm going on record saying this, but maybe this year we will see a better control of dengue.
Okay. Yeah, and that's like as I said, because we don't need another pandemic.
We don't need
another epidemic to deal with right now. That's good news then, and welcome. Now we have about 15 minutes, so we're sort of winding up. But let's talk a little bit about, where do things go from here? We've been living with this pandemic now globally since January. Okay, now we're sort of several months in, and it doesn't really seem as though the end is in sight really anywhere. What can we anticipate for the rest of the year in 2021, given that probably the only durable long-term solution to COVID-19 is as and when a vaccine is developed? Dr. Franco, Professor Franco, if I could start with you, where do you see things going globally, let's say in the next 6 months of this year? Where do you anticipate us being by, let's say, December 2020?
So you were mentioning the development of a vaccine, and if we look at in history, it takes 10 to 15 years to develop a vaccine, and there are still many diseases that don't have a vaccine yet. We are being very optimistic that in 1 year or 1 year and a half, we are going to have a vaccine. Right now, we have more than 130 vaccines that are being evaluated. 18 are being evaluated in humans, 2 are in phase 3. And they estimate that if they work, we might have vaccines available towards 2021. Now we need to talk about, we have a population, humankind is 8 billion people. And the amount of people that will require the vaccine is so large that we will need to produce them in a very large scale. And how will this be accessible in low and middle income countries compared to Europe or other countries that do have the economic capacity remains a question. So I think vaccines could be a solution, but they are, hopefully they will come, but there is still a long way. And probably a year or a year and a half will take for them to come.
Well, you said that's very interesting, because I've heard people say, well, 18 months and that's very fast. I didn't realize until then that the average time could actually be 10 or 15 years. So in fact, that's very ambitious and optimistic if we talk about within a year, within the end of next year.
That will be a record in history, and that is being optimistic enough that it's going to be a vaccine that is going to work. Because as I said, there are diseases that don't have a vaccine that work.
Yeah, and of course, the second point you raised is a good one, is just because a vaccine exists doesn't mean it's going to necessarily be available to all of the people who need to have it available. And I know that there are some movements around the world. We have a lot of prominent thought leaders, Nobel laureates, who've talked about making sure that a COVID-19 vaccine is a global good, is a global common good. Now, how important do you think such a process, such an understanding would be? Because, I guess if there's, one thing is developing a vaccine, but of course, if you don't get it into the hands of the people who need it, then maybe that's not going to actually solve the problem. Is that something that you think is really necessary moving forward?
Yes, it's essential that it's going to reach everyone, especially those that need it the most. And if you think those that need it the most are those that are most vulnerable, those that are poor, elderly population, indigenous populations, but they are the same people that have the least capacity to be able to purchase it. And at the end, what we see normally in humankind is that the rich people are the first ones and the ones that are protected first. So I hope humankind is able to coordinate the efforts and make the vaccine, once available, make it available, starting for those that need it the most, that are actually the low and middle income countries. But that is a hope more than a reality, because as you know, we don't live in a planet that is very fair.
Sure. And if I could bring Professor Faria in on this, what are you seeing in terms of Brazil, in terms of the socioeconomic impact of COVID-19? Is it something which is actually hit all segments of the Brazilian society? Because I know Brazil is a very stratified society economically. So how has this pandemic hit Brazil in terms of access to healthcare, access to ICUs and ventilators and oxygen? What is the impact that you have seen?
Well, the impact so far was huge, and I think that in the next months will be even worse, affecting all people in the country, not only the poor ones. We're talking about the health system, the hospitals. Even the private hospitals here in Brazil are dealing with a huge problem, because in this first 2 or 3 months, most of these hospitals stopped all kind of elective procedures. So the hospitals were empty. And now these hospitals are dealing with a huge financial crisis in the moment when they now have to be prepared to the impact of the COVID-19. So even hospitals in the private system are going to deal with unprecedented financial crisis.
Mm-hmm.
What is next? I really don't know. For the whole population, I think that we will have to get used to a new normal. Social distancing, wearing masks. This will be the rule until we have the vaccine. I'm maybe a little bit more optimistic than Oscar regarding the vaccination. I think that I have worked with immunization for 2 years in my postdoc, and I don't see a reason to believe that we won't have a vaccine. It doesn't seem to be this difficult to develop a vaccine to the coronavirus, but we never know. So I'm a little bit more optimistic. We have the vaccine, but we for sure in Brazil we're not waiting for that until the first trimester of the next year or first semester. We know that if the vaccine hits the market by the end of this year, all the vaccines available will go to the Northern Hemisphere, who will be entering the winter. So we know that we'll be the last ones to get vaccine. So we'll have to get used to this new normal. And Rajiv and Oscar had a paper published about what would be this new normal, about some period of time on, some period of time off, with more restricted rules of social distancing. This was a very interesting paper. They can comment on that. But that's how I see the situation in Brazil for the next months.
Okay, Rajiv, if you could come in. You have mentioned, Professor José mentioned your paper, but could you expand on that a little bit? Where do you see things specifically in Bangladesh, but also in general in the world, going over the next 6 months or even the next 12 months?
No, I agree with both Oscar and José that I think while vaccine is a possibility, but it will still take a long time for people to get a shot, in the low and middle income countries, for all sorts of strategic and practical reasons. So what we can do from now, well, our paper talked about more kind of a concept rather than a prescription. So our concept was that how you can make a balance between economy and life, saving lives. So both are important. I don't think they're mutually exclusive. I think we have to, take care. This debate has gone too far, in my opinion. I think we have to make sure that both are equally important, and that not prioritizing one, like economy, by completely forgetting about health or lives is productive. I don't think that's the right idea. So what we talked about is that whether we can have a system where social distancing can be applied and lifted in a periodic manner, so that we can control the disease, keep it under control of our health systems. At the same time, we can keep the economy breathing. Now, WHO has recently actually suggested a 14-day on, 14-day off, such kind of cyclic lockdown in Pakistan, which the government, I understand, is. I mean, as Oscar said, it needs to be locally appropriate. So it doesn't mean that this kind of periodic lockdown will have to impact the whole country. It could be zonal lockdown that could be periodically done. And I think we're heading towards that future anyway, where there would be periodic lockdowns of different regions or states or cities. And unfortunately, until we get the vaccine, that seems to be the future, the new norm to me as well, alongside masks and all the other preventative strategies to put in place.
Okay, thank you. Maliha, what do you think? 14 days on, 14 days off. Do you see that as a possible way out here for Bangladesh? Something along those lines?
Well, I'm fine with it if you give me the capacity. If you have enough ICUs, if you have enough CCUs, all the critical care units, I'm fine with it. But as we
Yeah.
see, when you lift the lockdown, there's a huge surge, and we need to impose we need to continue with some sort of lockdown measures. Whatever the policymakers decide, it's up to them. But we have to, I would reinforce that, as Oscar said, that it is culturally what matches with your people, you do that. What you can do, you do that. For me, I would reinforce that you have to break it down to the basic understanding of people, what social distancing means, what mask means, why you have to use masks, why you have to be more in an open air, why you have to keep 6 feet apart from each other. These are the things. You have to reinforce these things, and community level awareness, citizen awareness. These are the programs. Because if Zafar, if you remain well, I remain well. We don't live that far apart. If my household people remains well, I remain well. So it is, as he said, Oscar said, there is a pandemic. You have to understand that. It's everyone's business. It's a problem for everybody. And regarding the vaccine trial, I would urge Rajiv, Dr. Oscar, Dr. Faria, that think about Bangladesh as for your 3rd or 4th phase vaccine trial. Think of us. We can also do the test. You can imagine doing the testing here. We have a big population base. Why not?
Okay.
Can I just add there very briefly? So I completely agree with Dr. Maliha that all interventions, whether vaccine or social distancing, needs to be locally tailored, context specific. And what the government should do, 2 things: to speak with the communities to make it tailored to the local communities, but at the same time also to consult with the voices of reason, if you like, the experts, the local expert. I think in many countries the voices of the local public health epidemiology experts have been ignored. I think that needs changing if we really need to make a difference. So talking to both the public as well as the experts, locally and internationally, I think would be very important to future proof our interventions.
You seeing that kind of endeavor elsewhere? Or is this something which would you say is worldwide as a problem? People are really solving this problem individually, country-wise, as opposed to trying to solve it as a global community.
I think it varies from country to country. Many countries there has been good collaboration between the policymakers and the scientists. I think there are lots of good examples. There are also examples where that hasn't been done very well. I think that needs improving, in my opinion. But it's critical that we put science in the middle of in the center of our policy making. Otherwise, we keep talking to the local communities to implement those ideas. I think both are equally important.
Sure. Now, Dr. Franco, if I could let you have the last word. We're almost running out. I know you mentioned that, of course, whatever solutions any country has in place needs to be local. It's not one size fits all. That said, could you point to certain countries where you think they have had really good solutions in place, which could possibly be signposts, milestones for other countries to learn from? Who do you think has managed this the best in such a way that their experience is applicable and can be applied to other countries as well? It's not something which is unique only to that country.
So far, all have done what they could in the way that they could within the resources they had. I mean, if we look at now the report from the Deep Knowledge, looking at the best countries, how they came out of the pandemic, or how they could come out, both in terms of policies, economy, health, etc. The country that is in the number 1 is Switzerland. So I have to say we did the best job. Sorry, but beyond that, I have to say that we keep on forgetting that this is a temporal crisis. And pandemics are a consequence of the destruction of the planet. That is the challenge that humankind really has. And the recovery, it doesn't matter if it's in Bangladesh or in Switzerland, it has to be ecological, it has to respect nature, and it has to take into account planetary health. That I would like to leave as my last word.
I think that's great. And I think on that note, thank you very much. This has been a really fascinating discussion. Thank all four of you for joining us. We typically don't have discussions like this here in Bangladesh. And I agree with what Professor Franco said, that you should really try and look at this COVID-19 pandemic in the context of an ecological issue here in the world. And maybe, what it really is kind of like a wake-up call to all of us, that maybe the way we have been living our lives for the last 50 to 70 years need to be completely rethought in terms of our relationship to the planet we live on. And maybe as well, and this brings in the issue of if and when a vaccine is found, who gets to use it, our relationships to one another, and to really reaffirm the fact that we're all in this together. So thank you very much. And this has been a Tribune Talks, and thank you to all of our viewers for tuning in. Thank you.
Thank you.
Thank you so much.
Thank you.